Hey, everybody. It's 4 o'clock. We've been waiting for 4 o'clock on this date, at this stage, for a long time. We have any nurses in the house? Are you a nurse? Come on over. Any nurses? Do you work with a nurse? Come on over. Do you hire nurses ever? Come on over. We have a big announcement regarding nursing. Is there anybody that wants to hear an announcement about nursing? I hope so. I'm John Mark Green. I'm the Director of Innovation at CHIME. We want to thank you all for coming. We have a big announcement that's going to benefit everybody, down the road. But I just want to say thank you for coming. We really are excited about being here. We're excited about sharing the news that we have. And I just wanted to give everybody a chance to come up and get a seat, get some good seats, okay? All right. So I'd just like to welcome here on behalf of CHIME. We have been planning this for a while, and you may have heard of the ChIME and CHIME challenges. ChIME and CHIME have been working together for the past year. We've been basically doing something that providers were asking for a long time, and we were trying to figure out a way to make it happen. And because of the partnership that's developed between ChIME and CHIME, we've been able to help provider organizations find solutions, save time, and save money, hopefully. The ChIME challenges were, it was an interesting story. I'll let Chris tell the story. But the upshot is that a lot of providers wanted to work with startups in the healthcare space, but they didn't have time to do the vetting. They didn't have time to find companies that they felt comfortable with the level of innovation risk or non-risk that was out there. So as CHIME, we wanted to benefit our membership and find a way to help with that. And so that turned into a partnership with ChIME. And with that, I want to bring Chris from ChIME up here to explain and tell you the backstory, because it's been a ride. We did the first ChIME challenge debuted a year ago at Vive. It was the patient engagement challenge. And then we did the workforce challenge. And now we're going to do another one. And he's going to tell you more.
Thanks, John Mark. All right, so I went in early this morning and I put $5,000 cash somewhere in this room. I'm going to give you some hints on how to find it. You just got to know where to look, right? It's easy to find something in this room, right? If I give you the right clues, you should be able to uncover $5,000 if it's just laying around. My name's Chris Spearman. I'm the Chief Strategy Officer at ChIME. We are a health tech innovation marketplace. We match emerging technologies like the ones here with established healthcare organizations looking to solve critical problems. We look for your pinch points, we look for your pain points, we listen to your clinicians, we listen to your population health, and we help to identify the places and spaces where innovation could jump you forward. We look at not only clinical outcomes, but bottom line impact. And we help to risk assess these companies to say, what is the best matchmaking we can find? Because that's really the critical part. This is not a best in class, let's go measure all these people against one another. It's all these systems are different, all the support structures are different, all the personalities and places are different. So in order to do innovation, you gotta understand all the players, the parts, and help stratify those so we can solve for real contextual problems. So somewhere in this room, there's $5,000 hidden. It's at the intersection where patients are listened to and understood with the problem they present. It's in the place where frontline workers, particularly nurses, are cared for and given all the tools they need to do their job well. It's at the place where they get to work at the top of their credentialing, not settling for tasks that are outside the bounds and scope of who they are and what they do. Somewhere in this space is that type of solution, and in that type of solution, there's a big bucket of money hiding for you to find. So if you want some other hints later, come see me. I'm glad to talk you through where those might be. The announcement we're making today is in partnership with CHIME. ScaleHealth is launching a nursing innovation challenge. It's to look for, source, select, and assess the companies that are helping nurses work at the top of their skill level. And today we're bringing in a couple of our folks who work in this frontline space to talk through what that might look like. What this is going to result in is a clearinghouse of all types of different technologies working in different swim lanes, how they support better clinical outcomes and bottom line improvement. In a few months, CHIME members from around the country will have access to this report and can look in and see what these technologies are, what they do, and connect directly with the people who run them. We want to make this process of doing innovation better, faster, more efficient. We're here to help. I want to bring up Kat from our team, and Terri, you guys come on up. I'm going to let you talk more about what we're going to do and the problem we're going to address.
Thank you, Chris. I'm Kat Cramey. I'm the VP of Healthcare Operations at ScaleHealth. It's an honor to be here today. And more importantly, so I have the opportunity to speak with Terri Couts, who's the Chief Digital Officer for the Guthrie Clinic. She's also a nurse by training. We're going to spend a few minutes to discuss with Terri some of the initiatives and successes and challenges in the nursing, specifically around nursing, as part of our announcement of the Nursing Challenge. So thank you so much, Terri, for taking the time today. So last February, if I'm not mistaken, the Guthrie Clinic launched a virtual nursing initiative to challenge some of the pain points around high traveling nurse costs in response to the staffing shortages around nursing and some of the nursing crisis that we saw coming out of the pandemic. Would love to hear from you. What was the impetus behind launching that initiative at the Guthrie Clinic? What were some of the challenges that you faced in implementing that? And ultimately, how were you able to make it successful?
Sure. So I serve at an organization that's primarily serving rural patients in the state of New York and PA. About a 10,000 square mile region. We have 6 hospitals. In any given geographic, it could be 2 hours to get to one place to the other. A lot of the areas do not have cell phone coverage. We have broadband issues. And guess what? We have recruiting issues. And so then you have the challenge of the pandemic and people leaving because they felt unsupported. And for the first time, we had this experience where we had so many travelers in our system. Like we had quality and patient experience that was, and patient safety to be frank. Not only the finances, because obviously $7 million in traveler spend is huge for an organization that's already in the black or already in the red. But then you have the patient experience and the quality outcomes that also will drive revenue loss because of not hitting your metrics to face as well. And then other people aspects of it too. So just not having patients covered. So we started. So I actually have the honor of sitting at a table where I can listen and learn from operations staff to hear the problems that they're facing. So earlier today I was having a conversation and somebody said, "You used to be a nurse." I'm like, "No, I'm still a nurse. I still provide patient care. I just do it in a different way." And so a lot of my time is about going out and talking to staff, understanding what the issue is. And I was seeing and hearing that we had patients that were not being covered for simple things like fall risk. So we do a lot of one-to-ones to make sure that the patients don't fall in the hospital, because that costs the hospital a lot of money, and it also is not beneficial for the patient. And I just happened to be at a conference similar to this where I got introduced to a product, and I was like, I bet you that might actually help us. And then we started going down the conversation of, what else could it do? And just asking additional questions. And so we started out with telesitting and had it was easy to get it in because my CFO was like, well, that's a true ROI. Now one person sits for 16 patients instead of one, and so I'm saving 15 people, the cost of 15 people, over and over and over again. But then when we started looking at how can we use this same technology to drive different outcomes, and so we just started down this road of developing what we call the Guthrie Pulse Center. It's a centralized command center that has virtual components and operational components in one space, and looking at care model redesign enabled through technology, and started having questions around, could we do a virtual nurse program? Could we start looking at tasks that this product can help us with? But also, it's really about process change and just being able to scale it at a point where we actually saw some outcomes. And just started diving. I mean, we did a pro forma. We looked at our patient safety events and said, what could we influence with this? So medication errors is one, right? So you have an overworked staff that's running around, alarm, and we have higher medication errors. What can we influence with this technology and change the way that we provide care? We had a nurse in the ICU that would take about 33 minutes to leave their space, to go find another nurse, to leave what they were doing, to come into that space, then do a second sign for a medication. It takes 90 seconds in our Pulse Center because they use technology that drives efficiency, that gets them the help that they need at the time that they need it. Oh, and the patient doesn't experience that negative outcome. Same things with blood administration. We had a lot of blood waste. So we just started driving down what can we influence. And then we held true to that when we actually implemented. So we looked at things that would allow us to drive the ROI that we were looking for. Not everything's going to have that easy ROI like the telesitting, but if you're driving towards a goal, then you start to see those outcomes that happen with enabled care through technology.
That's fantastic. And the work that you did, I believe, earned you the award of the the Innovator of the Year award for CHIME. So congratulations on that. So you talk about the use and leveraging of technology to be able to deploy various initiatives that kind of together become part of your command center, right? Can you speak to any of the other initiatives? You mentioned the virtual nursing, the virtual sitting. Is there anything else that's part of that you could speak to?
So we started out with virtual nursing because we had, particularly in our ICUs, we had a lot of travelers. Most of our nurses were 3 years experience or less, which is very scary. They don't have that intuition, they don't have that experience, and they don't have anybody to reach out to. So we really started because we wanted the virtual nurse on the other side to have that mentoring, coaching, phone a friend kind of support. But then we thought those nurses could also help us if we centralized our transfer center, all of the traffic in and out. The people that are taking the phone calls, they're EMS and paramedic, they're medically trained, but they don't have that critical thinking that a nurse has. And so they could actually help support the transfer center. And then we put in a centralized telemetry where teletechs are monitoring all of our hospitals across. We had a reduction in staff and the need for space in all of our hospitals, but also if there was a critical rhythm that they wanted somebody to look at, they go to that critical nurse that's sitting in that same space and says, hey, what do you think about that? And then there's that escalation process. We also have the telesitters, and then we're getting ready to implement centralized bed placement because, again, it's about that throughput. It's about maximizing our resources, not just from what hospital that you go into, but what bed is best for that patient at the time that they need to be served. And it could be influenced by staffing or services or all these other things. And so we're doing centralized bed placement, and then we also have our EICU in that same space. So intensivists that can serve all of our ICUs depending on the capacity of that space. Yeah.
That's fantastic. Thank you for that. The two areas in the nursing challenge that we're focusing on are a couple things that you've touched on. So one is reducing the administrative burden for nurses so that they can spend more time providing value-add services, all right, and spend more time at the bedside and not necessarily requiring the 30 minutes it takes to go get someone to sign off as a second signer for a medication change. Similarly, if there are certain tasks like admission or discharge planning that can be done from a virtual nurse, so that the higher acuity patients get the attention of the bedside nurses. So those are some of the things that we're seeing kind of across the industry. On the other side of the equation is how can you use technology to enhance care delivery? And so some of the things that we've heard, and I think, and let me know if you're doing this at Guthrie, we've looked at fixed cameras in each of the rooms, right? So that you can basically do more with less. You mentioned with the fall monitoring, being able to leverage one staff member instead of 15 to be able to see your the entire unit. So are there any other areas across the organization where technology is being leveraged to identify those areas for efficiency with a focus on enhancing care delivery or reducing the administrative burden?
Yeah. So I would say we did put a fixed camera in every room, two-way speakers. It actually has an AI platform that sits on top of it, so there's some enhancement there. We're looking at ways that, because there's the computer vision and also there's the ability to hear things, can we use that technology to then develop other ways to serve efficiencies, like automated documentation, like for pressure ulcer reduction. That's all about whether or not you turn the patient. And if everybody gets busy and they forget, is there a way that the system can alert us that turn wasn't done? But also, if the turn was done, can it document it for you? And so looking at ways to think, broader than the actual problem at hand, but lifting all of that work from the nurses. Even from a patient experience standpoint, we're looking at, can we use that technology to enhance their questions or the need that they have at the time, or maybe a family member comes in and they weren't there during rounding, can they engage that virtual nurse to help support so that the nurse at the bedside can continue to do the work that they're doing instead of having to be pulled in? Or maybe patient education can be delivered a little bit differently at the time that the patient is ready, not the time that the nurse can deliver it because the nurse is really busy at the bedside. And so just looking at how we can use the technology, we did take a platform kind of approach. And so when we looked at it, we did look at it from a 5-year plan. There were some mishaps. There were some things we didn't think about. So when we initially deployed, we used mobile cameras. Well, then that takes a lot of logistics on whether or not you can move things in and out. So that's why we made a decision, no matter what room, we're putting fixed cameras in. We wanted that expense up front, but then we can utilize it for multiple use cases. We didn't think about that patient experience of the virtual nurse program initially, from the concept that all they were hearing was somebody coming out of the speaker, right? And so that could be a little alarming. So now we're integrating it with the ability to see it on their television on the other side. So they have that personal interaction with the nurse. But then also, hey, we could probably do virtual registration that way too. And enhance our, because that registration staff actually is something that we struggle with as well. Or could we use that same thing for consults? There's a lot of transfers that happen because there's a neurology consult that's needed. But a lot of times they don't need to stay in that facility. So could we do that consult virtually on that same platform in that patient's room? They never have to get moved and then they get served. And they probably have a shorter length of stay because a lot of these things take time to organize. And so just looking at it a little bit differently allows you to kind of expand. I can tell you when we first started, it was me pushing it because I saw a need. Now I formed a governance committee around it because we're getting so many asks that we have to say, okay, now we have to back off. Like, is this the right place for this, or can we consume it, or what's the outcome that we're trying to look for? It's kind of flipped itself on its head.
You bring up an interesting point because a lot of time when we introduce innovation, there may be some initial resistance because intrinsically people are resistant to change. And so it sounds like everyone's on board now, but as you were rolling it out, what were some of the challenges that you faced with your existing staff, and how did you overcome them?
The cameras was a challenge. Nobody likes to be watched, and so they, understanding the why, the purpose, and how they were going to interact with that camera. So we made sure there was a lot of etiquette around it. That they helped design that etiquette. So there's a doorbell that rings when somebody turns on the cameras, almost as if you were knocking on a door, like if you were entering the door into a room. We actually brought in the nurses and had. We used a lean management system, had the nurses help design the workflow, how they would interact, even what services they would influence. We went a little kind of slow at first and then ramped up once they saw the value, because once there's a win, it flies like a rumor. I mean, it's and I can tell a little story about that. So we had a patient that came into one of our lower level hospitals, was in cardiac shock, was very, very sick. They knew they had to life flight him to our trauma hospital. They called the transfer center to organize that flight. The transfer center turned around to the virtual nurse, the critical care nurse, and said, "You have a really sick patient in the Corning ED. You might want to get in there and help that nurse." They chimed in to the room. They helped organize all the documentation, helped walk that nurse who wasn't prepared to take care of such a sick patient. They organized the intensivist to come in and support that hospitalist who also wasn't prepared to take care of that patient. They helped organize the bed at the Robert Packer Hospital to make sure that when that patient got there, they had a bed, and that patient walked out of the hospital 10 days later. It happened all in like 2 hours time frame. That would have taken hours beforehand, and that nurse felt supported. The documentation was done. That there was nothing to kind of follow up on afterwards. The patient had an outcome that probably wouldn't have happened otherwise, and it was all about that coordination in the room. And so understanding like all these components, it's like they wouldn't have worked. They would have been siloed before. It would have been departments calling departments and trying to organize care, and it happened like that because we thought a little differently. We thought about the care model that we were trying to deploy and how we needed to change that.
And I think you've developed a process that could be replicable across other health systems, I mean, as a case study of success. But that's not always a blueprint that other health systems follow. So if you had advice and I know there may be some in this audience, but definitely at this conference, if you had some advice as far as adopting the process in which you went about vetting the technology, adopting the technology, and the constant change management that was required for its success, what would that be?
So I would say start with the problem you're trying to solve, not the technology. Because once you understand the problem, you can then fit the technology. And I think that's what Scale is going to offer, honestly, is that if you go to them with a problem, they're going to have a lot of solutions that they can introduce you to that can help vet that process out. But start with the problem. Make sure you communicate a lot. I mean, even it's a year old, we've had a lot of successes. We've saved $7 million in travelers. We've reduced our time and chart for each nurse per 12-hour shift by 30 minutes every day. So that's huge as well. And so you think about all the things but I still have to talk about the why. I still have to make sure that the process is being followed. I still have to go and talk to our hospitalist who maybe doesn't want the intensivist help. And so it is a lot of communication, a lot of rounding, a lot of understanding, a lot of trying to make sure that the change, because change is personal, and change is iterative. Like it doesn't happen overnight. And so there's just a lot of communication. And don't forget all the stakeholders. So like the patients and all of the other people that you need to pull into the fold. I would just say that, starting with the problem and then understanding what you're trying to solve and then applying the technology. Yeah.
So that's a good segue to the Innovation Challenge itself. So Terri, this is your second challenge that you're part of. You were part of our Workforce Challenge. And just for everyone's awareness, we now have 12 health systems who are partnering with us on this nursing challenge across the country. This is a challenge that is affecting every health system in the U.S. And to your point, what Scale Health and CHIME are doing together is listening to the industry, listening to the major stakeholders, and understanding what the pain points are. And so part of our process in defining this challenge, for example, is speaking with each of the key stakeholders that are partnering health systems, really understanding what the pain points are, synthesizing, consolidating those into the challenge prompts. And so that's how we arrived at the two major categories around reducing administrative burden and enhancing care delivery. And so defining that challenge in a very informed way, I think this is one that's definitely touching many, many health systems. But then going through a process of curiosity and willingness to experiment. And a lot of the solutions may not be fully validated or vetted, in the industry, but going through these innovation challenges gives them an opportunity to apply their solution to an identified problem, to your point. So at Guthrie Clinic, what has been your experience in adopting innovation? What is the process from a procurement standpoint, from just kind of an internal stakeholder alignment perspective? You mentioned it's not just the key decision makers, it's the patients, it's the nurses, it's the providers. So what's kind of the ethos behind adopting innovation at Guthrie?
So I think, the healthcare sector is probably the most risk adverse, less likely to adopt change, or sector of in any industry. But we do it for a good reason, right? If we mess up, we hurt somebody. And so we're all in healthcare not to make money, but we're in healthcare to influence and take care of patients and serve our communities. So I think, we do take the approach that I hate the word pilot because pilot's like where projects go to die in my sense, but we do try to understand. So we take a smaller sector of deployment so that we can say, what do we need to change? And we have that rapid change. I think that being agile and being rapid makes the adoption more palatable for our caregivers because they see that change right away. They don't have to suffer through something for long periods of time. It's really hard in an IT world to consume all the things that we're asking them to consume. And so being there and supporting them in that rapid change so that you can actually have a successful project. I think also making sure that we don't just implement and walk away. And so it is a partnership. It's a partnership between the vendors, a partnership between our IT services and our caregivers. And I think even holding our vendors a little accountable to the outcomes that they say that they're going to do. I write that in every contract because to me, I heard somebody talk yesterday, and he said, in the retail space, if it doesn't work, you can return it. You can't do that mostly in the healthcare space, and so I took that because I was like, that's really true, and so holding our vendors accountable. But I think it's really just constantly working through that change. It's not likely going to work the first time. I gave you a couple examples how it didn't work the first time, and we had to change to say, oh yeah, we didn't think about that, and being okay with that because failure isn't really about failing, it's about learning fast. And then if you learn fast and then you can implement those changes, then the adoption becomes more real.
Fantastic. Well, I want to make sure we have a few minutes in case there's any questions from the audience. But before we do that, any last words for people who are interested in applying to the Innovation Challenge? Anything specifically that Guthrie is looking for related to nursing that you haven't solved yet? Because I'm sure there's some things you haven't quite figured out yet. But anything else that you'd like to let people know?
I think there's lots of things to solve for. The nurses for a long time has been the backbone of an organization that, just took more and more and more and more and more. And it took a pandemic and a shortage to actually actually call out that we need to support our nurses differently, which is a little sad, but also, the time is here, and I think if you're interested in joining the challenge, I think that they provide a lot of opportunity for you to see things that you might not have seen before. Almost kind of like online dating, right? You can kind of swipe through the things you don't like, and then you can talk to the people that you do like, right? It's a similar kind of concept. They do all the work for you. That's what I liked, is that it was easy to consume. I knew exactly the risk level of each of the vendors. They did a lot of the background work, and the data was really valuable to help us with just processing through the risk. Because when you work with startups, there is a risk. But I also think when you work with startups, they can be just as agile as you, as fast as you want them to be too, which is a benefit. For us, I mean, we're still looking at efficiency gains and really trying to staff so that they can work at the top of their license, and really just providing joy back into the care. I mean, there's nobody wants to have that feeling of not being supported, and that's where we got to before we actually started to address it.
Bringing the joy back to it. That's great. So just some quick thank you so much, Terri. Really appreciate your insights. Excited to have you as a participating health system again for the Nursing Challenge. Just some kind of logistical information about the challenge. So we are officially announcing it today, launching it next week, March 5th. Open submissions will be available for 1 month, and then we'll be reviewing all of the submissions. And the finalists will have an opportunity to present live at the CHIME Innovation Summit in Jacksonville, Florida, early May. I suggest if any of you are interested in it, check out scalehealth.com. We'll have all the information there. You'll be able to go to the landing page specific for the CHIME Challenge. And welcome any and all ideas. And I'll open it up to the audience for any questions. Yes. Oh, thank you.
Thanks, Terri. That was fantastic and very informative. With the virtual nurses, how do you handle the alarms or real alarms versus all the alarm fatigue from a distance? And then my second question with the startups and the vendors, when you do I don't like the word pilot either. I call it be a pioneer, right? Like, let's pioneer this and try to advance healthcare. When you are a pioneer for a vendor, do they have to tap into Epic, go through all the cybersecurity, all of that prior to going live with the first patient?
Yeah. So for the alarm fatigue, we did work with a company that integrates into our EMR that allows us to kind of manage those alarms. We have communication tools that we also, because our virtual nurses don't sit in the hospital, they're actually at a remote location. And I did that on purpose because it was new, and I know that if they needed staffing, they were going to pull those virtual nurses. So I made sure that they couldn't pull them. So just another thing to think about. But they do document in Epic. All the data is in the same place. We communicate. They are part of the care team. They have assignments just like a regular nurse at the bedside. And they have, depending on if they're a critical care nurse versus a med-surg nurse, they have different kind of task that they do. But they do have the ability to engage that way. So it's through integration into the EMR. The second part of your question is absolutely they have to go through our cyber and our contracting process, and primarily because we have to make sure that we protect the patient's data and our healthcare system. And I'm sure everybody's aware of the recent cyber event and how impactful that can be on a healthcare system. And so we have started to build that into our contract and having an assessment early on so that we understand our risk. Of course, it could still happen, but most healthcare systems that get impacted by a cyber event is through a third party.
And on that note, as part of the Innovation Challenge application process, there are a couple of information security and HIPAA assessments that you would need to fill out as we do that initial vetting process for all of our health system partners, because we understand the procurement requirements to be able to work with them.
Paul Lure with Big Data Studios. Quick question for you about how important is it to market or at least provide patient engagement from a multilingual or also demographic information too? Is it to harness that personalization?
Yeah, so we don't have a lot of diversity as far as language goes in our community, but I do think it would be really important. We acquired a hospital a couple years ago that has a very large Ukrainian population, and we weren't prepared to take care of that. And so we did have to kind of course adjust and understand that. But it absolutely, it's kind of like bringing in all the stakeholders that I talked about earlier. You really have to understand the stakeholders that you're serving and how it's going to impact them, because the technology, honestly, is the easy part. It's the process and the people change that is the harder part of innovation.
Any other questions? Great. Well, thank you so much for joining us today. We're very excited to officially launch the CHIME and ScaleHealth Nursing Innovation Challenge. And thank you again, Terri, for your time today and being one of our participating health systems.